she came in with a very big heart attack. She had a total of about 15 electric shocks. At that point, hope was already been lost.
So what are the common risk factors that you see over and over again that put people at risk for heart attacks and, stenosis and obstructions and things?
Think to simplify it for your audience. We have risk factors that can be modified, and we have the non-modifiable risk factors. Let me start with the non-modifiable risk factors. Increased age, I cannot change your age, Dr. Smith-Bay. I cannot make you any younger.
Okay. Fine.
Correct?
Fine.
Neither can. maybe in the decades we'll be able to do that. One other thing I cannot do is I cannot change your genetics.
Right.
Okay, I cannot change your family's tree and your genetics. However, there's certain things I can change. Under the modifiable category, we have clinical factors, which include things like high blood pressure, which we call hypertension, high cholesterol levels, diabetes, obesity, or metabolic syndrome. Okay, these are things that to some extent we can control. But then we have another group of modifiable risk factors, which I call lifestyle modifiable risk factors, which would include diet, sedentary lifestyle or inactivity, sleep, stress, very important, stress, smoking. These are things that literally you can change in a very short amount of time. And all this risk factor contribute. But for the purpose of this conversation, I'll focus more on the modifiable risk factors because that's really what we can change. So
right. So let's talk a little. Let's tune in more to those modifiable ones because that's what we can work with. So, I guess my first basic question is, how much of what you treat do you think could have been prevented?
A significant amount. Yeah. It's important to understand that when autopsies were done in teenagers, we're able to find that coronary artery disease, a plaque buildup, starts occurring mid-teenage years.
Wow.
So you already have the foundation being laid for you. It's a lot of times that it now boils down to, do you let that foundation grow into significant clinical coronary artery disease, or it remains as subclinical? The plaques did never get bigger, or they never rupture, and things of that nature. So understanding that we all, some way or one way or the other, have some form of, and this is part of aging, inflammation, have plaques. It's important. And I think understanding that, paying significant attention to these modifiable risk factors can significantly decrease the incidence of what I'm going to use for you is clinical coronary artery disease, not subclinical. So the full-blown manifestation of CAD. This part of medicine cannot be overemphasized, actually.
No.
It is so important. It's a completely big field in cardiovascular medicine called preventative medicine.
What do you tell patients after a stent that might surprise people?
Okay. So there's a popular misconception that stents save lives.
Yeah.
That I'm not saying they don't, but it's only in a specific subset of situations. Let me delve in a little bit. When we treat blockages in blood vessels of the heart, there is degree of severity to blockages that can cause different kind of manifestations. Okay. First of all, the recommendation is you cannot place a stent in somebody who does not have at least a bare minimum moderate to severe blockages. Okay, so that's the criteria. I mean, or very just high risk lesions. But then, as we go further, we realize that there are emergent conditions with those blockages, and there are stable conditions with blockages. In stable conditions, we call it stable coronary artery disease. In emergent situations or relatively urgent situations, we call it acute coronary syndrome, which means the degree of severity of the blockage is a lot higher, but this is an impending heart attack about to happen.
Yeah.
Okay? So if you use a stent in someone who already has heart attack or very critical stenosis, you could have a chance of perhaps you've decreased that person's mortality. However, if you use a stent in somebody who has stable disease, who at rest, they don't feel discomfort, but when they move around and they exercise, they're having discomfort or shortness of breath or manifestations of significant coronary artery disease, you might not ultimately increase their lifespan. But what you've done is maybe symptom control. There was a very groundbreaking trial that came out within about 5 years ago called the ischemia trial. And I think it really changed the way we cardiologists thought about revascularization. And what we know realized from tens of thousands of patients, we were able to realize that in moderate to severe disease, coronary artery disease, with patients with stable symptoms, they were stable, which means at rest, they were comfortable. If the medical management of these patients using medication was equally as effective as using stents. So when you tell patients this, they are shocked. Why am I getting a stent when I could just be treated with medication?
Yeah.
But again, I think it's about finding the right subset of patients to use whichever one for it. So I think in my early career, most people always thought that, or I always thought that stents saved everybody's lives. But no, it's actually a relatively small subset of patients. Those are the acute coronary syndromes that you can decrease mortality in.
So how can patients advocate for themselves when they have to face a major decision?
I give a general guideline. These are fields where, if you have to make major decisions with a cardiologist, there has to be a level of understanding of the disease process. You see, in medicine, before we do procedures or we do any major interventions, we have something called informed consent. And what is informed consent? There should be a discussion, an interaction with the treatment parties, the physicians or the healthcare team, and the patient and family, discussing what is this diagnosis?
Yeah.
What exactly is going on, the disease process? What are the possible treatment modalities of this disease process? Do we need to do intervention? Do we need to have medications? And so pretty much you're telling the patient about alternative treatments. Now, the question is also, what happens if we don't fix? And what happens if we fix? And what is the recovery time? The best thing a person can do is have somebody be actionable when they have questions. They have to actually move, which means if you do not understand, get somebody who can, to some extent, understand. It's not about being technical, but who is able to give some support. So there has to be some preparedness. You write down, you ask questions, and who is able to help in that regard. And I always tell patients, if you don't feel comfortable, always get a second opinion. Perhaps the next professional, the next healthcare professional can give you better insight into the disease processes and maybe or not, maybe not. That could be the deciding factor of whether a patient lives or dies.
Yeah.
Because we should not forget everything we do, majority of what we do, despite, the goal is to do no harm intentionally. Yeah. Everything we do has risks, no matter how small they are.
Awesome. Thank you so much. Well, with that being said, I'm going to go ahead and close us out, but it has been so good just picking your brain. And I appreciate the time. I appreciate what you're doing for our community, especially as a Black cardiologist, Black interventional cardiologist at that, is incredible. Continue to sorry.
I'm so sorry. Can I say one thing? And I think because you said as a Black cardiologist, because this is an area of my passion. This is an area of passion for me. And this is also an area of interest in also my earlier career in medicine, which is, health disparities in medicine.
Right.
And certainly in cardiovascular outcomes is where I'm interested, is an area that is very dear to my heart.
Wow.
I think for your audience, it's also important to note that social determinants in medicine is one of the major driving factors for cardiovascular mortality in America.
Yeah.
I'm gonna. I think. Please pardon me to talk about a quick study which was done in Tulane, where they were able to, I think, access the health data for about 50,000 patients, and what they were really looking at, association of these various risk factors, including clinical, lifestyle, and social determinants of health. When I say social determinants, I'm talking about income, food, access to jobs, or being married, and things of that nature. When they corrected for age and sex in these patients, they found out that the Black patients had 54%, about 50, mid-50s, 54% more higher cardiovascular mortality, despite just correcting dead white patients, 54%. So what they did was they went ahead and they corrected for the clinical risk factors: hypertension, diabetes, hyperlipidemia. Despite that correction, it was about 34% higher in the Black patients. Then they went ahead again and they said, you know what? Let us correct for just the lifestyle risk factors. It became 31%.
That's it. Still.
Yes. Still higher. Then they finally decided, let's correct for social determinants. Even.
Wow.
So that's a food for thought for our audience. And we still have ways to go, in educating our community and giving the best possible service to our underserved patients.
Absolutely. And I mean, if I had had time, I would have picked your brain a lot more about that. But if I can ask one more question, since we're still going a little bit, is there anything that you feel like we can do differently, both as patients and as doctors and clinicians, to make some changes?
Education.
Mm-hmm.
Education. I think knowledge is power. And we're gonna, this is not just patients and doctors. This is people. the whole community. People. It's a human right to have health, access to health. Yeah. I see it as a right, and something as a right. It should be afforded for just living. So I think we just need to educate ourselves, and again, there's from that study to significant initiatives that arose from it. But not to delve deeper into it. Yeah. If I had to pick one thing, I'll say education.
Go for it. Yes.
Education. When I say education, it's not just with the treatments. It's early education. What can we do to prevent these disease processes from even fully manifesting? So once we start educating from a very young age, can we realistically remove social disparities completely?
Yeah.
Maybe in a utopian world.
Yeah.
But we always strive to do that. But what can we do for ourselves that at a very early age that alleviates the disease processes is starting early education and being very aggressive with preventative medicine in underserved areas.
So good. So good. Thank you. I'm excited for this podcast, guys, because he's just dropping some gems. And if you need help with further education, if you want ideas for advocacy, check us out at Tree of Life Integrated Family Medicine. Feel free to look up Dr. Kiladejo. He is incredible. Hopefully you won't have to see him in clinic, but he's changing lives every day, and this podcast is a part of it. Thank you again for your time, and we'll see you guys for the next episode. Take care.